even if you said, okay, my cycles are regular, but I'm not ovulating, that's another problem. Or if you say I have regular cycles and I'm ovulating, but I have abnormal spotting in the middle, or I have brown bleeding at the end, or I have brown bleeding at the beginning, however you want to say it. I have pain that's intense. Even if I have regular ovulatory cycles and I have those symptoms, that still could signal that there's a problem.
Hello and welcome to this latest installment of the Natural Womanhood video interview series. I'm really excited to be here today with Dr. Danielle Koestner. Dr. Kesner is a family physician who's been practicing full scope family medicine and obstetrics for over 10 years. She is also the Chief Medical Officer for FEMM. And we're going to be hearing a little bit about that today for those who aren't familiar with FEMM and their fertility awareness method and their medical protocols. So Dr. Kesner, excuse me, I made that mistake again. I swore I wouldn't, but I did. Why don't you introduce yourself a little bit further for our listeners, our viewers, and then we'll dive into the meat of what we're going to be discussing today, which is some of the latest research around endometriosis.
Sure. Okay. Well, thanks for having me, Grace. I really appreciate it. I love the work you guys are doing. I know it's so beautiful, the education that you guys are getting out there. So I really want to thank you for having me and thank you for the work that you guys do. But yes, I am family medicine and OB and trained in Michigan and did a dual residency family medicine and OB, which is kind of a unique thing to do. And then I worked for 10 years in the underserved, really taking care of a lot of patients with Medicaid or no insurance. And then I left there to go sailing with my family for a few years and did a mission we called NFP by Sea. And then while I was on that mission, we got asked to go to Africa with FEMM to teach Cornell. Weill Cornell has a medical school in Africa, and the bishop there runs the hospital and the medical school and asked if we would come and teach our women's health program to their OBGYN residents there. So we did that for 6 months as a family in Tanzania, and the outcomes were incredible already. One of the doctors has published a case review, which is great. And then we came back and we've been doing telehealth with FemHealth now, and just growing that platform. Really the goal to provide access for this type of healthcare, really good women's health is what we like to call it, right? And evidence-based women's health for every state in the US. And then we do have a lot of international patients as well. So it's growing fast and it's really beautiful and fun to just really help women get to the root cause of what's causing their issues with their cycle.
Wow, that is, gosh, you've lived a lot of years in your life, or a lot of life in your years, I guess is the phrase I'm looking for. That's incredible. I love hearing these stories, especially about teaching fertility awareness methods to women from all walks of life, all across the world, because obviously, some of the false pushback against fertility awareness is that, oh, women aren't motivated enough, especially if they're not educated enough, or it's too much information for some women to learn these things about their bodies. It's just easier to, put them on the pill or what have you. And gosh, it's just so untrue when you look at the work of people like you and the work that FEMM has done, especially globally, because, women with low literacy, no literacy,
They can do this.
They can understand this. They just need somebody to be dedicated enough to teach it to them, right? And so
Right.
I love hearing that that's part of your story, because I beat that drum all day long, that this is information not only that women deserve, but that they can take in and appreciate and utilize.
Yes. And that's why actually I went towards FEMM, because I had taught other methods and I love them all. I have no issue with anyone. And I never make patients change what they're charting when they come see us. But what I found in the underserved is I could have them download the free FEMM app and get started charting their period and their mucus right off the bat. And they could come back in a month and I would see if they were ovulating or not, in a very rough way. It wasn't perfect.
Yeah.
But it worked. And I could use it from a medical standpoint to to help point me in a direction. It wasn't that I used it for diagnosis per se, but
Yeah.
with the lab's ultrasound and that chart, I really could put together a picture of what was going on for that woman without a bunch of formal training, right?
Wow.
So from a medical side, it's just a great way to go.
That's really interesting to hear that. And I know that that is kind of one of the big features of FEMM is the app, right? That
Right.
it has kind of more of a savvy technical capability, or at least did earlier on than some
Yeah,
of
it
the
does.
other methods, which makes it consequentially really great for teens. And that's kind of going to be a little bit of the focus of what we're talking about here today, because we want to talk about some of the latest research in endometriosis. Fortunately, endo is getting there's a lot more visibility around it, I feel, than there ever has been. You're seeing young women write up their testimonies in different publications, and we have a podcast episode on that with a young woman who wrote her testimony for the free press. So, and the title of it was great. It was something like, "I wasn't crazy, I was sick," and it was about
Right.
her journey to getting diagnosed with endo. So there's definitely a lot more visibility around it than ever before, but it still does seem on the whole that women are still being diagnosed much later in life than they should be. They're in their 20s, they're in their 30s. Maybe it's only because they're trying to get pregnant that they even find out that they have it or suspect that they have it. But these are things that we can actually take care of when girls are in their teens, not long after they start cycling. We can start diagnosing and treating these things. And we're going to talk about that today, because that's a major mandate we feel like we have at Natural Womanhood, is to get this information into every woman and girl's hands. But the earlier we can get this information to younger and younger women, and for girls and teen girls, their mothers, the better off they're going to be in the long run, health wise, and even emotionally and mentally. So let's dive into that. Why do you feel like FEMM has kind of this unique ability to be utilized for treatment of reproductive disorders, especially endometriosis, and particularly in the teen set?
Sure. Right. Well, of course, as you know, many patients and young women might have painful cycles, and their mothers might have had painful cycles too.
Mm-hmm.
And a lot of times their mother was told this was normal, just buck it up, deal with it. And so that can be repeated easily generation to generation.
Yeah.
And so it's important that what you guys are doing, getting the word out and helping mothers, because a lot of mothers are coming saying, hey, I heard there's something else I can do with my daughter so she doesn't have to go through what I went through.
Mm-hmm.
And of course, I like the FEMM app with the option of, in the settings, I just have the mothers and the teen turn off things they don't need, like they don't need intercourse or temperature or, LH testing and pregnancy testing. Turn
Yeah.
those off. It turns into this perfect little teen app, and they can turn those things back on later when they're
Mm-hmm.
ready for that at some point in the future. But FEMM has always existed, not necessarily, we never existed to just be a method of natural family planning. Actually, we didn't even want to have a method ourselves. We just wanted to focus on evidence-based medicine.
Oh, interesting.
And we tried partnering with different organizations, and that's water under the bridge. So, but we did create a method based on the science that already existed, that was already published. And that's how our method came to be. And the mission was always the medical side.
Okay.
How can we change the standard of care for women, focus it on evidence-based medicine? So every part of all of our protocols and this little protocol book and this big protocol book is all based on research and evidence-based medicine. So our goal was to stick in that sphere. Really, as you know, we don't call it RRM, we call it women's health. And it's very important. Why? Is because it is just good women's health, and all doctors should be doing it. None of our protocols are a secret. They're available for every doctor everywhere.
Mm-hmm.
And we really want them to dive in, and we want this to become the standard of care for women. And so that's really our focus. So people will ask us sometimes, aren't you going to research FEMM for effectiveness in avoiding and achieving pregnancy? No, we'll probably never do that, because
Mm-hmm.
we don't really care about that part. We know that the evidence is that can work for those purposes, but most of the reason that we exist is to help women get the better access to women's health care that they deserve. So it doesn't actually matter which cycle chart they use, as long as it's tracking ovulation, we can use that chart to then help dig in with labs and ultrasound to diagnose and treat whatever's going on. Let's say in this example with painful periods or painful cycles.
Mm-hmm. Yeah, that's interesting. I've never, I didn't really understand myself that FEMM was kind of an amalgam of just different methods, and that it just sticks to the science of fertility and reproduction. And so that makes sense to me. Everything that you were saying about almost not even really considering it a method so much, and not really having like kind of these insular protocols that you keep to yourselves and need to validate individually, because it's all just based on what's out there, the science of the cycle and reproduction and fertility. Very interesting. So let's jump into endometriosis more specifically. Give us, for our listeners who might not be super familiar with it, please, if you could, briefly describe endometriosis and what we know about this disease that I read a statistic the other day affects as many women as diabetes does. It's that prevalent, and yet
they're associated with each other.
yeah, that too.
Right.
Yeah.
Yes,
So
exactly.
yeah, give us some background on that, please.
Yeah. Yes, a very basic, high level, right? The endometrium of the uterus is just the lining that's shed during menstruation. So when that lining grows outside of the inside of the uterus and it grows into the abdominal cavity, whether it's on the bowel, on the somewhere attached on the outside of the uterus, or on the ovaries, or on the fallopian tubes, it's where that tissue is now growing outside of the uterus, and it's still being shed at menstruation. And that's where women get all that pain from, is that bleeding inside their intrauterine cavity during that time, or just leading up to that time, right? The week before my period is a common thing that women will say, or the first couple days of my period, or around ovulation. There's different times where that endometrium will cause them pain.
And so pain is one of the primary hallmarks of the disease, right? But there are also some other symptoms that are associated with endo. What are those?
Sure. Well, of course, some women don't even have pain. So that's important to say,
Yeah.
that some women don't have pain. Someone will present with just an ectopic pregnancy, right? That's the first symptom they had, was a baby got stuck in their tube. And then we look late and we go and look, and there's endometriosis there. But women can have a lot of symptoms. And of course, we don't really know truly if it's endometriosis unless we look with laparoscopy. So we go inside and look. We can make some guess. There's some blood tests that you can use that will tell you if it's very advanced endometriosis. There's some really cool new tests coming out. But the gold standard is to look with laparoscopy. But the other symptoms that women might have are everything that involves with ovulatory dysfunction. So they might have PMS symptoms. They might have just mood symptoms, maybe the week before their cycle. They might have, interestingly, autoimmune symptoms. So they might have like a nickel allergy, is a common associated with endometriosis, right?
Wow.
Like they're just allergic to cheap earrings, or they notice when they wear a necklace that's not real, they'll get a little rash. It also can be associated with dermographism. This is where the skin is really sensitive. It's also associated with insulin resistance, as you noted how common it is and how common insulin resistance and diabetic disorders are. So lots of different symptoms that a woman could present with. But whenever a woman presents with abnormal cycle, in particular, abnormal pain, bleeding, or anovulation, or not ovulating normally, that's when we want to look and see what's going on.
And that can start pretty early too, right? Especially
And most of the time it does. If you ask a 35-year-old that's presenting, if I asked her back when she was young, often the story is it started around the time of menses, right? Around the time they first got their period. And often they might even have irregular cycles too. There's an association with PCOS as well. And, so They might come and say, yep, I've always been irregular my whole life, and most doctors told me that was normal.
Mm-hmm.
Wrong, right? We're just trying to tell doctors all the time, please don't ever tell a patient that's normal. That's never normal, right? I mean, I guess it's normal if you're breastfeeding or postpartum, or
Sure.
there's times when it's normal,
Yeah.
but it's not normal in a teenager that's been menstruating for at least a year. They need to be regular, and they
Yeah.
shouldn't be so painful that you have to miss school or miss work, or
Mm-hmm.
right.
Right.
And bleeding you shouldn't have more than 2 to 3 days of medium to heavy bleeding. That's too much,
Yeah.
right? More than 2 days of medium heavy bleeding is too much.
Yeah.
So trying to help women figure out what they're feeling and is that normal or not normal.
Yeah. And to go back to something you just said, I think there's that time period in teens, especially when they first start getting their periods, right? And it is irregular at first, and that's normal. And that's so there's a tension there, right? Where we can be too quick to say, "Oh no, this isn't regular. We need to regulate it." And often that's where we see young women being put on birth control.
Sure.
But it is normal, at least in that first year or so, give or take, to have
Right.
irregularity. So let's talk a bit about what's like kind of the normal irregularity of a body that's just beginning to cycle versus the irregularity that signals that there could be an underlying issue like endometriosis.
Sure. Right. That's a really good point, Grace. And I think a lot of doctors have said different things over the years. And the newest research, if you really dive in, says about 1 year a woman has to get regular cycles.
Mhm.
And it's really never normal to have intense pain that makes you miss school, or that's never normal.
Okay.
Okay. And it's never normal to have bleeding that's more than 7 days, or bleeding that's, more than 2 to 3 days of heavy bleeding. That's not normal either. And when you have so much pain that just ibuprofen isn't working and you have to miss school or work, that's not normal either, even
Mhm.
if it's in that first year and you're just irregular there. But after 1 year, we want to see regular cycles with ovulation.
Yeah, and so by regular too, what's
Yeah.
the what's the where that's the day length that we're looking for to determine
Yes.
regularity?
The consensus right now that's published is 24 to 36 day cycles
Mhm.
and ovulatory.
Mhm.
They have signs of ovulation.
So that's a pretty wide range too, because again, the standard textbook cycle is 28 days, right?
Sure.
So I feel like there's a lot of misinformation still about what's a truly irregular cycle, and it has to do with it both being outside the bounds of that pretty wide margin of 24 to 36, and
Yep.
then also irregularity between cycles in cycle length, correct?
Sure. Sure. And I think even more importantly, even if you said, okay, my cycles are regular, but I'm not ovulating, that's another problem. Or if you say, I have regular cycles and I'm ovulating, but I have abnormal spotting in the middle, or I have brown bleeding at the end, or I have brown bleeding at the beginning, however you want to say it. I have pain that's intense. Even if I have regular ovulatory cycles and I have those symptoms, that still could signal that there's a problem. So really, you're never wrong to say, hey, let me just get checked and make sure this is okay.
Mhm.
Right.
Yeah, I
But
think that's a great point to make, is that it's never going to be a bad idea to get things checked out if they're outside of, what should be regular, especially in a teen girl who has gone a year from since the time she had her first period, pretty
exactly.
much.
That's right. Or if in that first year, the pain is too intense or the bleeding is too intense, then that's reasonable to get it checked. And then what we have been using as at the Reproductive Health Research Institute is a guideline of no more than 3 abnormal cycles in a year and
Mhm.
no more than 2 in a row. So if you have one abnormal cycle, usually maybe you can write it off to something, right?
Yeah.
I'm talking anovulatory or irregular, but if there's 2 abnormal cycles in a row or more than 3 in 1 year, then we want to have an evaluation.
Mhm. Yeah, and that makes sense because if you figure, about 12 cycles a year, 3 out of
Mhm.
12 is a quarter of your cycles. So,
Is abnormal. Then we
yeah.
gotta check.
That definitely makes a lot of sense as a benchmark. And so
Mhm.
that too, right there is where it's so important that as soon as our young women start cycling, as soon as they start seeing that first period, that we know we have a tool that we can give them, whether they're writing it down or using an app like the FEMM app, that they're tracking these things, because the only way that you're going to know whether or not it's regular, how many days are going on, if you're seeing signs of ovulation, is if you're monitoring these signs and you're
Right.
recording it in some form or fashion, right?
Right, exactly. Well, it was really fun. In one of my teen daughters, we gave her the teen femme training when she was before
Mhm.
she started her periods, and she found her first ovulation. And then she said, "Oh, mom, look." And then we said, "Okay, maybe about 14 days ish, then you'll get your period." And she did. And it was really fun to see. She could
That's
see her first
incredible.
ovulation before her first period. She was really prepared, you know?
That, oh gosh, I want to live in a world where that's the reality for every single young
Isn't
woman.
that
That's
cool?
incredible. Her
It's so
very
cool.
first ovulation of her entire life, she
She
saw
sees
it.
it. Yeah.
That's amazing.
That was really neat.
And then so no one would ever in that world, right? No one would ever be taken off guard by their first period, which
Right,
is a huge fear for teen
right,
girls, for
right.
preteen girls, right? That you are going to stand up in class and it's going to be the day.
All
And
over.
yeah. So, gosh, yeah, imagine that world. And that's the world that we're striving for at Natural Womanhood for sure, where
That's
every
great.
young woman has the opportunity to catch even her very first ovulation. That's
That's neat.
awesome.
Mhm.
So, I think too, here we need to put in the disclaimer about getting irregularity checked out is that you do need to make sure you are seeing a doctor or taking your daughter to a doctor if the person you're concerned about is your child, um, to a physician who understands everything that we've been talking about so
Yeah,
far, because the reality is they're few and far between.
yeah,
That problem is slowly being corrected as more physicians like yourself, crop up, but still, the reality of the world that we live in is that the vast majority of either family practice or adolescent health or OBGYNs that you would take your teen daughter to or that you would go to as a young woman would just put you on the pill for any of
right.
these issues we've talked about.
Well, and I used to do it as a doctor, so I
Mhm,
totally have compassion on these physicians. I
mhm,
feel they just don't know what they don't know,
mhm.
and some of what they know isn't so. And that's why we exist at FEM was like, okay, first we need access in 50 states to start taking care of women. So we have that. And now, now we have 4 doctors, and then we doubled our nurse practitioners and our PAs. And so it's just growing really to provide access. And our hope is that you'll give us your doctor's name and we'll send them notes back with a note that says why we're doing what we're doing. Here's
Yeah.
where you can review the research. Here's where you can come for the training because it is just normal medical CME credits,
Mhm.
continuing medical education credits. And it's fun because every year we're inviting more and more doctors and our space grows more and more. And eventually this will be the standard of care. I feel confident in
Yeah.
that, right? Because medicine eventually catches up. Especially like when we were in Africa, it was just an IVF doc had come the year before
Mhm.
us, and they
Mhm.
had like one live birth that year. And then we came and they had 40 live births within the next year just based, I mean, these protocols are something you can do in Africa because
Yeah.
most of the underlying issues are things that are pretty common and pretty easy to treat with old, safe, cheap medications that are highly available. So, anyway, I think that it will become the standard of care because there's much publications around it. It's just getting the word out for physicians that
Mhm.
this is there. And
Mhm.
all you have to do is just switch the medicine you're thinking about for the patient, right? Instead of the band-aid approach, why don't you treat the root cause and prevent all the other things? And that's, Grace, one point I'd love to make is anyone listening to this, if you think about your family history, think
Mhm.
about grandma, aunts, uncles, dive deep, everyone. Is there any autoimmunity? Is there any diabetes? Is there any cancer? Is there any um, other women with painful periods? Did they lose their uterus for some reason? Did they have miscarriages, infertility? whatever it is, that stuff is often, there's some genetic component there. So yes, we always want to talk to patients about diet and exercise, but so many doctors are stopping at diet and exercise, and they think that's the only thing they need to tell patients about. And vitamins and supplements are beautiful, but a lot of them don't work. And so, or they don't work enough, and they don't get the full relief or the full fix of their ovulatory dysfunction that's causing maybe, let's say, endometriosis or whatever else is going on. So that is something to think about too, when you really think about your family history. That's the stuff. A lot of women come to us, like in Africa, of course, it was infertility. That's what they wanted treated.
Yeah.
And very common in the US too, where women are coming because they heard we could help them get a baby. And
Yeah.
so, yes, of course, we want to help them get babies. We love them. But it's so much more than just the baby. It's about being a grandmother too. And it's about preventing all these cancers and heart disease in your family too.
Yeah.
And so, yeah, I think it's really important for people to think not just about their periods and their ovulation, but what is that that's running in their family that they really want to prevent, and how can we help them do that?
Yeah, that's all really great advice for anyone listening. Because yeah, especially if you are struggling with infertility, um, you can have that single-minded approach of I just need to get to the point where I can conceive.
Yeah. Or I need
And
my period to be regular, or
mhm,
I just need my luteal phase to be normal. It's so much more than that, right?
mhm,
It goes so much deeper into, well, what caused that luteal phase deficiency?
mhm,
What caused that low progesterone? That's what I hear a lot. What caused the anovulation? What's causing your pain?
mhm,
And therefore, what's causing the cancer in grandma,
mhm,
Um, or the dementia, right? Dementia is being thought of as type 3 diabetes. Well,
hmm,
that's associated with abnormal ovulation, pain in the cycle, inflammation in the uterus. So a lot of insulin receptors on the uterus and a lot of prolactin receptors on the uterus. So these are common things that are easy to treat. Within 30 days, a lot of patients find, oh, my pain is way better, right?
hmm,
And the symptom I know, Grace, that a lot of girls are going to come with is depression and anxiety,
hmm,
especially in the teenagers. That is probably their most common presentation. They actually don't even tell me about their period yet. I have to ask about that. Oh, yeah,
hmm.
it is kind of painful. But they actually often come with anxiety or depression. And we can commonly think about using depression and anxiety medicines, and not that that's wrong, but some of those medicines will increase prolactin.
Mhm,
Many of them do.
mhm.
And then that can cause worsening of their endometriosis. And of course, it does help their depression and anxiety. But then we never treated the root cause of the depression, the anxiety,
Yeah,
or the endometriosis, right?
yeah.
And so it's okay to use those. And if people need them, we want to use them, and we can treat the prolactin that it causes, right? With safe things.
Mhm.
If there's a way to get even deeper into the background of why they have anxiety or why they have PMS or why they have pain, that's what we want to do. We want to dig a little bit deeper to that root cause.
So let's get into that then, because prolactin and the association with prolactin and endometriosis is only something that's really recently
You.
come on my radar. And not that I'm a physician and read all the medical journals, but I do work at Natural Womanhood, so I do keep my finger on
Yeah,
the pulse of
something.
these things. So when I see something come across that surprises me, I have to think, wow, this is new. This seems like something of a breakthrough. And you had shared with me some interesting new research, in particular about the association of prolactin and endometriosis. So what are we seeing around that hormone in particular? Let's talk what prolactin is, what it's supposed to do,
Yeah,
and
good
some
point.
of the associations that we're seeing now with
Sure.
prolactin levels and endometriosis.
Sure. Okay. Now, if anyone has a computer in front of them and they just want to like look at where is this picture, but basically prolactin comes from the anterior pituitary, which sits right behind your eyeballs here in your brain. So right under the hypothalamus, there's a pituitary, and it sits in this little saddle in the brain called the sella turcica. And in that area, there's other hormones as well. TSH for the thyroid comes from there. FSH, follicle stimulating hormone, comes from there. So that's where prolactin comes from. And it comes in a pulsatile fashion. So it comes in pulses to your body. So it can be high at times and low at times. So getting a one-time prolactin is really great, but we're really trying to focus doctors on it, if they can, definitely getting a pooled sample, which is where you check it and then 20 minutes later, you check it again. Same thing, check it again. So at least 3 draws of prolactin. If you catch it high at any time above the standard, there's a new article that was published 2023 in the Journal of Pediatric Adolescent Gynecology. And it says the normal prolactin for women of ovulatory or reproductive age should be 9 plus or minus a standard deviation of 3.4. So basically, it really shouldn't go higher than 13, right? And that's very commonly higher than 13. So if physicians are finding it higher than that, they should really be treating it. It's not a long-term treatment. The treatments are old, safe, and cheap. And it's like you can literally use lower than the normal dose that you'd treat like clinical hyperprolactinemia with. You can treat it at the half tab once a week and, or every 10 days, or even once a half tab every 15 days. So very, very low doses, very safe, really barely any side effects. Most women do not have side effects from that medication. And you only need to use it for about a year or 2. In young women, just a year, and older women, maybe 2 years. And then it does tend to reset the pituitary. And prolactin, when it's high, it's going to go into the brain and mess with dopamine, which is going to cause those anxiety, PMS, mood disorders. It's going to increase adrenal hormone DHEAS. So they're going to develop PCOS. They're going to present with acne as teenagers, right? In particular, they might have those little pinpoint acnes on their forehead, or they might get that like beard-like pattern and maybe start to develop little hairs on their chin, maybe around the nipples or the areola, even on their abdomen between their belly button and their pubic bone. Now they're starting to move towards that PCOS, but that's originally caused by the high prolactin. Now, also high prolactin causes a problem in the ovary where there's an increase probably because of the increase of androgens in the adrenal gland, they're going to be more likely to develop insulin resistance.
Right.
And now insulin resistance is going to cause a problem converting testosterone to estradiol. And now these patients are going to have high testosterone levels too. Inflammation is going to be abound because of insulin, let's say, and they're going to be developing now these insulin glucose metabolism disorders. And that's going to lead to more problems with inflammation and pain, polyps, fibroids, endometriosis. And you can just go, anyone that wants to check the research, please do. Patients are looking on Google all the time. So I tell doctors, don't let your patients know more than you do. You go on there and type in PubMed, endometriosis, cabergoline, PubMed, endometriosis, hyperprolactinemia, whatever you want to type in. But you'll see the association in the articles. And that was all I did quickly, just to send you a few articles, because there's just so many. I could put a bunch of them in there, but really, why not have people just go look for themselves and see that there's many papers. Some are better than others, right? So that's our job as doctors, to really get through some of that research. But patients are welcome, and other doctors who might be listening to this, please go and look at that research. There's no secrets and there's nothing hidden, right? It's really just out there for you to see.
Yeah, and it is encouraging to hear that there is more research going into endometriosis, probably than ever before. There's more of an interest in getting into the why, because so many women do experience it, and it is one of the leading causes of infertility in the United States and probably globally as well, right? So it's good to hear you cite a paper from 2023, because that means that people are actually researching this today, that this is not ancient research, and it's informing how you're treating patients right now, obviously, and it can inform how other physicians treat their patients too.
Right.
So again, let's just reiterate too, when should a patient or their parent start seeking help for suspected endometriosis, and what, if they're trying to help inform a provider who might not be
this is
on
the hard
board
thing.
yeah, with what's going on, but it at least might be a little bit receptive to some guidance. What kind of tests should uh, parents or patients be
Sure.
expecting to undergo it with
Right.
suspected endo?
Good. Yes. So we do three different things with every patient that comes, and
Mhm,
it's charting, right? So we'll ask her to chart at a minimum. Some of them already know what to do. And at a minimum, we'll have them download the free FEMM app and just get started. So I do a 1 minute teaching. Here's how
mhm,
you do the bleeding. It's either heavy, medium, light, spotting, or brown. And then the mucus is either dry, pasty, moist, or slippery. And
mhm.
we briefly describe those. And I just want them to get started. They don't have to touch it, stretch it. They just have to pay attention, look at it, pay attention as they're walking. I know that sounds way too
Yeah.
simple, but it does really work when you just give it to women
Mhm.
in that way. And then, of course, we'd love for them to see a teacher at some point, but to start there. And if mom
Yeah.
and daughter will do together, like a mother daughter, like what you guys offer, one of your courses, or our Teen Femme course, or Billings has a Teen Star program that I love. There's just so many
Mhm.
great options out there, and we just don't feel that you need. I just love them all. I mean, basically, it's giving women this really good information. Um,
Yeah.
and then we'll do a series of labs called a basic hormonal profile. And that involves hormones from the brain, the pituitary, the adrenal glands, and the ovaries, as well as the pancreas, insulin, and glucose. So we're going to check all the hormones, the most important hormones in the body that we know of right now, right? We're always doing more research. And then the third thing is an ultrasound. And in teenagers, we typically tend to do a trans-abdominal ultrasound. So very simple,
Mhm.
jelly on the belly, kind of look at things, looking at the thickness of the endometrium and looking at the ovaries. How many follicles are there? Is there an endometrioma, which is a little like a, could you see? It's hard to see endometriosis on ultrasound. So if you already see one of those, that's a problem. One of the specific blood
Mhm.
tests that doctors can order is called a CA-125 and do it on
Mhm.
cycle day 3, 4, or 5. This is a common marker known for ovarian cancer, but we're using it it's published for use in endometriosis. If it's elevated, it usually means we're more like a stage 3, 4 endometriosis. And so our
Mm.
protocols will say to do pretty aggressive medical management for 3 months. And if we don't get success in that, then we'll send them for a surgical consult. But our surgical
Mhm.
rates are quite low because we're treating the
Huh.
medical underlying issues. So really, I think the amount of surgeries that we're doing has really decreased as we've learned these medical protocols. Okay, but
That's
other things,
interesting.
moms, daughters, what do you look out for, right? We've kind of already went through it. Painful cycles, too painful that ibuprofen, heating pads. I've had girls say they're going to pass out. They get
Yeah.
nauseous from the pain. None of that's normal. Um, they need to miss school or miss work. They have to take a whole day in their bedroom just to kind of get through their period. This all is not normal, right?
Mhm. Mhm.
Irregular cycles, and outside of that, 24 to 36 days without ovulation. So if they don't know how to chart ovulation, they should learn. Um, and as far as your local doctor goes, if they're amenable, sometimes local doctors will reach out to us and we'll help local doctors do the
Great.
work. That would be great. A lot of them really don't have time for that and we don't blame them.
Yeah.
So if you'll see us first, what we love to do is send notes back to your primary care doctor. And again, most of what we're doing is pretty old, safe, and cheap, and they can take over once the treatment's underway if they're comfortable with that. And then we're always inviting them to our training. So there are doctors that you might know that are interested in this area, but they don't know these medical protocols. Well, if they're
Yeah.
willing to, you can even tell them, hey, would you go to this training? You can even pay for their training if you want your doctor to know this stuff, right? And
Mhm.
some people do that. They pay
That's
for their
great.
doctor to come, or the director of the pregnancy center, they pay for that doctor to come, right?
Yeah.
To get these medical protocols. So yeah, I think that's the best way is just really the easiest is to kind of check out on our platform,
Mhm.
femhealth.org, click schedule telehealth, and then we'll see you first, get the workup, and then we'll send you back. We'll send notes back to your primary. And if they're
Mhm.
comfortable, they can either work with us or take over treatment. That's really great. I think we're just evangelizing a lot of doctors that way.
Yeah, that's great because there is that kind of knee-jerk response, I think, in our circles, maybe to just say, oh, to heck with the doctors who don't know any better. I'm not going to bother going to them. I'm going to drive 3 hours to go find a NAPRO doctor, or, do the
Yeah.
telehealth with FEMM at the outset, and not even try to go to a doctor who I don't automatically know up front is going to be on board with all these things. But I love that you use the word evangelize, because there is an opportunity for that, because like you said earlier on, what they don't know, they don't know. And so if you do have a good relationship with a doctor, or feel like there might be an opportunity there, that they might be receptive to hearing about some of this stuff, don't necessarily discount your local OB, or, the person who delivered your baby, but you would never consider, talking about fertility awareness too, you know? So I think that's a really great point, that we could definitely do better in the kind of fertility awareness community of give them a chance, to learn about this stuff before we just discount,
Right.
regular physicians, for lack of
That's
a
right.
better way
And
to phrase that.
understand that they just don't know.
Yeah.
And they actually probably became a doctor because they wanted to make a difference and they
Yes.
wanted to help you, and they just really don't know.
Yeah.
And if we never tell them, then shame on us,
Yeah.
right? And if
Yeah.
we don't keep up to date on the research, then also shame on us, because we are called to do that. And so
Yeah.
as we dive into this, we have that research arm, the Reproductive Health Research Institute, that's always reviewing other people's research and always collecting more research on our end. And so by seeing as you're helping us collect that research, right, we're using that information to help us inform more research as we go forward. But you're also then we're able to send it back to your doctor and give them this information too. I think a lot of times, I don't know if you feel this, Grace, but a lot
Hmm.
of times people say, well, I just think they'll think I'm going behind their back. And I'm like, I don't
Hmm.
think so. A lot of doctors send patients to specialists or
Sure. Yeah.
whatever. We're just a specialist in women's health. And
Yeah.
so we have no problem just sending back and saying, thank you for joint care of our patient.
Yeah.
If you have any questions, you can review research at PubMed, blah, 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 right? And also, you're welcome to come to our training. You just go to this website and click on research medical provider, and you're there.
Yeah.
So it's really it's not weird. It's really in line with like evidence-based medicine. And it's really
Sure.
important that we get away from that idea that this is something that is. And also, I would say it's important for doctors that might be doing something like NAPRO to say, hey, wait a second, where's the stuff I'm doing published? And should I then have a good research eye to say, is this really what's best for women? Ovarian wedge resections, all these endometriosis surgeries. Is this really what's best for them? And if it is, then do it, right?
Hmm.
But if it's not, and if there's something you could do and learn a little bit more about underlying issues causing it, that's causing you to do all these surgeries, please get that information. Don't
Yeah.
let it hold you back.
Yeah.
This is just good medicine. And
Yeah.
so we don't want, we want to keep all that research on the forefront.
Yeah. That's a really great point. And I think it's encouraging too to hear, because so many women here, and young girls, their parents here, if you're not going to put her on birth control, then you can try surgery, and those two
Yeah.
might seem like equally unattractive options to someone, especially with a young girl. So it's good to hear that there are other protocols out there that involve digging a little deeper in the medical management of these issues, without going to birth control on the one side or to surgery on the other.
Or
Um,
progesterone on the other,
mhm,
right? Like
mhm,
post-peak progesterone is a common Band-Aid, I think,
mhm,
for the underlying issue that's at hand.
mhm,
And so they're all a Band-Aid to the problem of anovulation or inflammation in the body. And so let's fix that problem.
mhm,
And then we'll fix her cycle and her pain, her depression,
mhm,
right?
mhm,
And prevent some of these things that might be running in the family.
mhm.
There's a really common association with these families with endometriosis, and then have Parkinson's over here, or rheumatoid
Wow.
arthritis, or there's a huge association with autoimmune diseases and high prolactin, associated with endometriosis. So we just see that there's this big continuum where you start as a teenager with this issue, and then you grow to an adult with autoimmune diseases.
Hmm.
This is a big problem, why we need to treat this way more aggressively, and really, especially if we have something old, safe, and cheap, we need to dive into that. There's a lot of new things out there. We don't know what those drugs are going to do to people, but when you have something so tried and true and old and safe, and you can use it in lower doses than the standard dose, it's really important that we try those things.
Like what, for example?
Okay, so most common, cabergoline. So again, this is a common drug that's published. So you could type in PubMed, Prolactin, and endometriosis, PubMed, endometriosis, and cabergoline, and just look at those articles.
Mm-hmm.
But cabergoline is an old dopamine agonist, so it works right in the brain to directly inhibit prolactin. We don't want to inhibit it far enough that it's abnormally low.
Right.
We want to make it right in that beautiful normal range. And within 30 days, most women's pain is really controlled. They'll come and say, wow, my pain is 80% better.
Wow.
50% better. It's really fast. And so it's just a really common underlying thing. And now if you also look up prolactin, PubMed, prolactin, and autoimmunity, you'll see an association with autoimmune diseases.
Mm-hmm.
So we're putting all those things together and saying, yes, more research needs to be done, but we're definitely clinically seeing an association with this at a young age, endometriosis, nickel allergies, autoimmunity, and then when they're older, they're developing things like rheumatoid arthritis or lupus or miscarriages or things like that.
Wow, that's super interesting. You're teaching me all sorts of new things right now. So thank you for
I've
that.
been there. As a doctor, I was prescribing birth control and IUDs and all sorts of things. And then I just got so burnt out. What is going on?
Yeah.
And I tried the Napro, like, let me just give progesterone. Well, that didn't work that great either. And then I was like, okay, let me just dive into what is all the research here and what is actually real and what's not real? Because sometimes we use things in medicine and we think, well, seems like it's working, but we're maybe not being honest with ourselves about what is this actually what's going on? Or is there something deeper that's causing this?
Yeah.
So we have a really great slide that I love to show. And I know we can't necessarily quick show a slide, but it shows the process of ovulation. And it's FSH first.
Yeah.
Then it's estradiol, which has to go up on this beautiful slope in the right way.
Right.
And then it's LH. And only then can you ovulate. And then only once you ovulate do you have progesterone, right? In an adequate level. So if someone has low progesterone, instead of just giving it to them, it's really important that we go back to the beginning of the process and say, what went wrong? So that we know, let's not just put the birth control pill or progesterone. They're both a Band-Aid. How can we actually fix the problem?
Interesting.
Yeah.
All right. Well, we are running long because this is also fascinating. No. I'm just there are more questions popping up in my head as you're speaking. But I think in the interest of time, I want to ask one final question and we'll wrap up with that. Because I can see someone who's new to everything that you're talking about, who's been struggling with painful periods and wondering what to do about it. I could see them fearing kind of diving into this world head first. It can seem complicated. It can seem new. It can seem just too different from what is done in the mainstream. And they might feel like, well, birth control has worked so well for so many women's pain, for painful periods and other things for so long. I'm just going to go on that and hope for the best, or I'm just going to put my teen on that and hope for the best. Why, in the case of endometriosis specifically, is going that route really not in your best interest, whether you're a teen or an adult woman?
Right, exactly. First of all, do whatever you want. You can do that, right? However, if you really want to worsen the problem, the root cause problem, that's the thing to do. Go on the pill and it will increase autoimmunity. So what happens to women on the birth control pill? Their cortisol levels increase. Just check. Any doctors that don't know this is true, just grab a couple of your birth control patients and check their cortisol. It'll be probably in the 30s.
Yeah.
Now, what happens with high cortisol in the body? They get autoimmune diseases. So now we're taking a woman that probably has an underlying issue that you're Band-Aiding with this Band-Aid, and it works, right? I'm not denying that it can help with pain. When you shut down ovulation, it does work. And in our protocols, we do have a way to do that. So we do have a way to shut down a woman's cycle in a very safe way if we have to. So let's say they failed medical management, they failed surgery, and we need to shut down the cycle. We're not going to use the pill. We're going to use Lupron, which is horrible, right? But we'll shut down the cycle, and then we'll do add back therapy. We'll give that woman back those hormones that she once was supposed to have in a normal way. We'll give them back in a normal way. So continuous estradiol, continuous testosterone, continuous DHEA, and then post-peak progesterone. We'll give it to them in that way if we have to shut down the cycle. But definitely the pill is not the answer. And in medicine, this has happened many times, right? Like we thought something was going to be so great and we gave it to women and then we saw all the bad things. And that's why I think at the Reproductive Health Research Institute and FEMM, we really want to be honest in the research. So if we are doing something over time that we realize isn't right, we'll stop because we're finding a better way. And so I think that's what's happened with the pill. It's just not the right way. And if you want to really just dive into that, when I first stopped prescribing it, I spent 3 weeks just online researching all these articles and I was floored. All of this research is there.
Yeah.
So it's actually not weird. And it's very much a well-known fact that this medicine is not good for women, in particular with endometriosis, because we're going to worsen the autoimmunity. We're going to worsen the inflammation, and lead to potentially infertility and problems in the future, just medical problems, cancers, autoimmune diseases, infertility, right? All of these problems. So we really don't advise that.
Yeah. Well, I think that's a great place to wind this up, and I'll put in a final plug for the research that can be found at RHIH and FEMM. You guys are doing a great job compiling all of this. And you don't have to feel like this is crystals and juju and there's data, there's evidence, right? And there are ways to treat these, endometriosis, PCOS, other reproductive health disorders that maybe your doctor might not have heard about, maybe your daughter's doctor might not have heard about, but that they might necessarily, not necessarily be opposed to if you can present them with the research. So important that we have that at our fingertips with, the work that we do at Natural Womanhood and the work that y'all are doing at RHIH and FEMM. RHRI.
And FEMM. Actually, if you want to look up the research that we have on our website, it's femmhealth.org, and then just go to research. So there's a whole link. But of course, you could just go to Google and see a lot of it too. Not all of it's ours. Right? We're looking at other people's research too.
Wonderful. Well, thank you so much, Dr. Kesner, for being here today with us. This conversation ranged even wider than I had originally thought that it would, and I learned so much, and I know it's going to be really edifying for a lot of our listeners to hear, and hopefully give them some actionable items for taking charge of their health, no matter their age, no matter whether it's their health or a loved one like a teen daughter. So thanks again for spending this time with us today.
Thank you. Appreciate it.